So, so if you look at this topic, there are actually 4 talks in this topic. But that's what Venki gave me. Thanks, Venki. So I'm going to try and summarize it in about 8 to 10 minutes, the salient points, and especially the compliance part, because as more and more of our going into practices which are run by the hospitals, we forget the compliance because we say somebody else will do it. But ultimately, it comes down to you to make sure that everything that you do is compliant and you get paid and don't go to jail. So these are my disclosures. So if you look at the lower extremity amputations, these are statistics from 2021, there were about 150,000 major amputations, that means below knee, above knee amputations, and the vascular etiology was about 82%. Risk of amputation with diabetes is 30 times greater, and more than $4 billion were spent related to the amputations. But if you look at the overall diabetic care, that is more than $300 billion spent by the healthcare system. So there are 4 pillars of limb preservations, and that's where all of us can play a role. The first pillar is medical management. Without good medical management, you cannot take care of the patients. First of all, we can avoid amputation, avoid diabetic foot ulcers, avoid a lot of things. So what is medical management? Managing diabetes, hypertension, hypercholesterolemia, exercise, preventing smoking, and all the other things that go with that. Use of antiplatelet drugs, et cetera, et cetera. The second pillar is revascularization. That's what we all hear about. You'll hear a lot of technology, a lot of techniques, a lot of innovations. We heard about PTAB last night. So revascularization, whether it be open or endovascular, there'll continue to be debate what is best, but this is what we do. So that's the second pillar. The third pillar is wound care. If we as vascular surgeons or interventional cardiologists or radiologists, we take care of a patient. Patient has a bad ulcer, we revascularize them, but patient has no place to go, because you can't find anybody to take care of the ulcer. And bad infections even despite revascularization, if the patient has very infected wound, they'll still lose their leg. So wound care is extremely critical, and partnership with the podiatrist is extremely important in making sure that we take care of these wounds. And the one which is most forgotten is neuropathy management. If you think about it, you have to go back to the days of leprosy when it was very common and people had insensate foot and lost their feet and ultimately lost their limbs. So this is my fourth pillar, which is usually not talked about. So these are the 4 pillars of limb preservation in my way of thinking. So what is the role of a vascular surgeon? Because he gave me the name vascular surgeon, so I put that title in the title. But I would say role of a vascular surgeon / interventionalist, because vascular surgeons do have one extra expertise that they can do, that is open procedures, but still 75-80%, somewhere in that range, can be managed by interventionalists. So we provide percutaneous revascularization, open procedure when indicated, and you can be leader of the limb preservation program. So can be an interventionalist. So other specialty providers you need, podiatrists, primary care, cardiology, endocrinology, hematology. This is the whole team: ID, nephrology, neurology, orthopedic surgery, plastic surgery, spinal implant specialists. Spinal implants have become important in managing neuropathy, and especially sometimes reversing the diabetic neuropathy, rheumatology and rehabilitation. Regulatory intention, that was the other part of the compliance, a part of my topic was. So you can be subject to targeted probe and educate plan by Medicare. That actually is not bad, because they come look at your charts, and if something they did not approve, then they tell you, they educate you. They come back and re-examine your charts a few months down the road. If you meet all the deficiencies, then you're done. But if you have not met, then there may be penalties. So in the wound care system, if they look at this has become very important: cellular tissue products, CTPs, or skin substitutes, and the level of debridement. When you're coding and billing, it's very important that you code it correctly. In the HPO, or the hyperbaric oxygen treatment, there are about 14 indications by CMS for which you can get paid. So if you're doing for uncovered conditions, you will not get paid. Number of treatments, they need to be pre-authorized, and missing documentation. If you don't document, you don't get paid. Keys to documentation: know what documentation is needed by procedure, indication, and document. And truthfully, I hate to use the word truthfully, but people sometimes bluff toward medical necessity. Know the covered ICD codes, and as again we go into more corporate practices, we forget the ICD codes, et cetera, CPT codes, because those are important. We still need to know them, whatever practice system you are in. Know the NCCI edits and the bundling. NCCI is the National Correct Coding Initiative. Compliance is the key to retaining payment. You get paid and then they come back and take the payment back. You have to have the right diagnosis code, right CPT code, right quantities, especially if you're doing debridement and skin substitutes, and thorough documentation. It's all about if it is not written, it didn't happen. And be prepared for NCCI edits and bundling. In 2023 March, OIG issued a report that found that manufacturer non-compliance with reporting requirements for skin substitutes led to millions and millions in excessive Part B payments. OIG noted that since then, Part B expenditure for skin substitute products have continued to rise significantly. In the new LCD that just came out, there are only 16 products that are approved by Medicare to be used. There are more than 100 products in the market. There are only 16 for which Medicare would pay. Compliance, you review policies and procedures, review NCDs and LCDs, billing and coding, keep chart master current. You may or may not be familiar, the thing that you fill out, which has all the CPT codes, and so you make sure that that is current, because as Medicare changes rules, you need to update those. So these are the new rules for skin substitute, just came out about a month ago. And in the CMS website, there's much more detailed. Basically, this is a synopsis of that. The presence of a chronic non-infected DFU having failed to achieve at least 50% ulcer area reduction, we documented standard of care. For a minimum of 4 weeks, we documented compliance. That means you have to treat these people minimum 4 weeks. And then all the things that you have done, if you look at the CMS website, they'll tell you, then you can get approved for a skin substitute. So debridement as appropriate to a clean granular base. Offloading is important. That's where the podiatrists and the plastic surgeons and the orthopods come into play. Sustained compression dressings for venous ulcers. Infection control with removal of foreign body or focus of infection. If there's infected wound, they will not cover skin substitutes. Maintenance of a moist environment and prevent smoking. Measurement of the initial ulcer and weekly measurement, minimum 4 weeks of treatment, ulcer measurement. Record must include an update medication history, pertinent medical problems, diagnosed in the previous ulcer evaluation, and qualified provider providing the care. Maximum 8 application. First, you get only approval for 4 applications, then you can apply for 4 more. You have to do more documentation. So this is the NCCI I talked about. Not all CPT claim will be covered. For example, debridement and compression, if you bill for both, only debridement gets paid. You do CTP and debridement, just CTP, the skin substitute will get paid, not debridement. But if you do HBO and debridement, then both will get paid. So how does the adding wound care help you? It increases your knowledge. Advanced wound care, normally we don't learn that in our residencies and fellowships. Evidence-based clinical pathways you can use for better outcomes. Efficient practice model for complex patients. Financially, it gives you additional revenue stream for clinical visits and procedures, additional revenue stream for MDs from hyperbaric supervision, increase in surgical volume. When we calculate X number of patients you see for wound care, what percentage will ultimately need revascularization and ability to recruit. Because if you make more money in your practice, then you will have money to pay a second partner. Otherwise, you may not be able to recruit. Thank you very much.